So welcome everyone. We are thrilled to have you join us today for our webinar, Master Predictable Root Canal Obturation with BioRoot Flow. During this session, we will have an in-depth look into the benefits of using BioRoot Flow for effective root canal obturation. This lecture will be featuring two incredible speakers, Dr. Lauren Kuhn-Newth and Professor Stéphane Simon. Dr. Lauren Kuhn-Newth has successfully used BioRoot Flow in over 1,000 cases, and she will be sharing her invaluable insights on achieving consistent, high-quality root canal obturation. And Professor Simon will be showcasing a remarkable 91% success rate of BioRoot Flow that comes with his 2 years clinical study. So, ladies first, Dr. Kuhn-Newth, maybe you want to start with your introduction?
Yes, absolutely. Thank you all for joining us this evening. I am so thrilled that you have chosen to spend time with us to talk about how we can improve care for our patients and the quality of our obturation long term. So I am an endodontist. I am board certified by the American Board of Endodontics, and I attended dental school at the Harvard School of Dental Medicine, where I graduated about 7.5 years ago. And then I finished my residency in Charleston, South Carolina, about 5.5 years ago. So I've been practicing since then, and BioRoot Flow is my material of choice for obturation, and I feel like it gives me very consistent results. So thank you for having me here today.
Thank you, and thank you for your introduction. And now moving on to Professor Simon, I'll let you introduce yourself as well.
Hi, yes, thank you as well for being here, because the bioceramic story for me starts to be a long pathway. I've been using them for nearly 10 years now, because I started with the BioRoot RCS. So I am Professor Stéphane Simon. I used to be a professor at the university, at Paris University, and now I'm back to a private practice only. And I'm also leading a big postgraduate courses company where we train dentists and endodontists, nearly 600 a year. And so I am endodontist. My practice is limited to endodontics since 2003, so nearly 21 years now. And I'm using the bioceramic for nearly 10 years now. And then the topic of my talk today is to present you a clinical research we completed 2 years ago now, because we have the feedback of 24 months, 43 months now. And then we compare the BioRoot RCS and the BioRoot Flow outcome. And I will tell you more about this research. And it's a very good one because it showed that the bioceramics works, definitely. And now we have the proof.
Thank you very much. Before we share with you all the presentations of the webinar, we would like to know more about our audience and to know about who joined us today. This will allow us to know who we will be presenting to, and to allow Dr. Kuhn-Newth and Professor Simon to adapt their answers during the Q&A session. So I will launch a quick 2-question poll. Okay, there we go. So you should see the poll on your screen. So the first thing we really need to know, or we would love to know, is what is your specialty in dentistry? Do we have more general practitioners in the room, or endodontists, or other specialties? So that's great. I'm seeing that a lot of you are responding, so thank you. I'll wait a few more seconds to make sure that we have as many responses as possible. Okay, so now I will share the results with you. Okay, I don't know, is it what you were expecting? Do you have any insight about what you're going to talk, how it's going to be interesting for our audience today?
I'm just wondering what other is. What is other? Are they dentists or vets?
Yes,
or...
they are dentists, but not everyone may be a general practitioner or an endodontist.
Oh, okay.
And it can be frustrating not to have anywhere to respond. So.
Yes, I think this is a great mix. So I've been teaching at the University of Minnesota School of Dentistry for about 5 years, and at least in the United States, the majority of root canal treatments are performed by general practitioners. And also, general practitioners, a lot of times, are the ones who make the initial call on whether something needs root canal treatment or whether it is even savable. So, for general practitioners to be knowledgeable on bioceramics, particularly BioRoot Flow, and to know what's possible, they will then either feel confident to treat the case themselves or feel confident that when they refer that there is a very good chance of success. So I think it's great that about 2/3 here are general practitioners.
Great, perfect. So I will now launch the second poll. So what we want to know is how often do you perform root canal treatment procedures? The idea is to know how confident or how used to practicing this kind of treatments are you? So in order to have a better idea of who is our audience today. So same as before, I'm seeing a lot of respondents, so I'll wait until it's about frozen to share with you the results. Yeah, it's still moving. Wow. Okay, I'll wait a few more seconds. I think it's about right. So here are the results, if you can see them. Yeah, can you see them?
Yes, we can.
Yeah,
And
okay, perfect.
that's interesting because I think that if you ask a question to a French dentist population only, you will have more than practice daily treatment procedures. Weekly and monthly, it's not possible. I think it's a very, very low number of dentists who do monthly endodontic treatments in France. It will be interesting to do the sample for a French population because we don't have the specialty as endodontist in France. So, and very few countries in Europe recognize the specialty. So I would say that maybe 95% of root canal treatments are performed by GPs. And as you probably know, I've been working on the pulp vitality preservation for 20 years. So as an orthodontist, I've worked hard just to push the people to keep the pulp alive. So hopefully they should do less and less root canal treatment. But the true story is that we do a lot of root canal treatment every day.
Yeah. We still need them today, but thank you.
Yes. Yeah, that is very interesting. And I think that the results of this showing that over 70% of providers answering are performing endodontic treatment at least weekly, so could be daily. I think that these are then providers who are making a lot of judgment calls on what is fixable, what's not fixable, what root canal treatments can be performed in one appointment versus two versus three, depending on what's going on, and when vital pulp therapy with something like biodentin, for example, might be an option as well. They're making a lot of judgment calls. So I think that this is a great result for people attending.
Perfect. Thank you. So I'll close the poll now. And so, well, thank you everyone for taking these polls. As you know, these results are very interesting for us and for the course of the presentation. So what we will do now is we will start the webinar. Just so you know, both Dr. Kuhnuth and Professor Simon's presentation were recorded in advance to avoid any connection issues. So we'll play them for you back to back. And at the end of both sessions, we will all meet here again to answer your questions and make sure that you leave with a deeper understanding of the topic. So now we're going to turn off our cameras and mute ourselves and share the presentation with you. We will be back at the end of both sessions in about an hour and 15 minutes to answer your questions. So sit tight, enjoy this great program, and we'll see you in a bit.
Hello, everyone. My name is Dr. Lauren Kuhnuth, and I am a board-certified endodontist practicing in Minnesota in the United States. I'm here to talk about BioRoot Flow, which is the syringeable tricalcium silicate root canal sealer from Septodont, which I believe provides predictable and high-quality root canal obturation results. These images on the screen are actually from when I did a root canal on my mother in early 2024, so just a few months back. And she caught me off guard with this selfie, but I'm happy with how it turned out. So she took this picture while I was doing her treatment, and then the x-ray on the left is of her tooth, which I obturated with BioRoot Flow. So a little bit about me. I attended the Harvard School of Dental Medicine for my dental school training, which I finished in 2017. I did my residency in Charleston, South Carolina, where I became an endodontist, and I am a diplomat of the American Board of Endodontics, which means that I am board certified. There are fewer than 30% of endodontists in the United States that are board certified, so this was a very exciting honor for me and something that I really cherish. I'm also a part-time faculty member at the University of Minnesota School of Dentistry. I started teaching there in January 2020, right before the pandemic. And I have published in a variety of peer-reviewed journals, and I contribute to a variety of social media outlets related to dentistry. I also have a disclosure to provide. I am a private practitioner and I teach at the University of Minnesota. However, I also do provide consulting and am a key opinion leader for Septodont, which means that I have received honorariums from Septodont when I speak about my experience with their products. I also would like to disclose that I have used BioRoot Flow, so I do have a great deal of experience with it, and I estimate that I have performed approximately 1,100 obturations with this material, and I started using it in November to December of 2021. I also want to mention that terminology during this presentation may vary. In our field of endodontics, there are a lot of terms that have not yet reached a consensus. So the terms bioceramic, hydraulic, calcium silicate, bioactive, or mineral-based might all be used to describe a sealer like BioRoot Flow. The same thing is true for obturation. Single cone technique, hydraulic condensation, sealer-based obturation, those will be referring to the same thing during this presentation. So what are our goals as dental providers? Well, the ultimate goal of dentistry is to retain a healthy complement or healthy set of teeth for a lifetime, and therefore appropriate strategies should be preservative. And that's the purpose of endodontics, is to save teeth. And how can we achieve these goals? Well, basically, we can break up this goal of saving teeth into smaller goals. We can remove the irritants from the root canal system. We need to prevent future recontamination of root canals. And then we want to eliminate and heal apical periodontitis. I also wanted to mention that all of the x-rays in this PowerPoint presentation are x-rays where I've obturated with BioRoot Flow, except for one, which I will clearly indicate. So all of them except for one are cases using BioRoot Flow, and they're all cases that I have performed. So I am happy to answer questions about them as well. But these are our goals, so let's dive deeper into them. So first, when we're removing irritants from the root canal system in order to save teeth, we have to identify what are these irritants anyway. Well, typically they are bacterial in origin. So we know that if pulp is exposed, but there is no bacteria, such as in germ-free rats, which was indicated in the Kakahashi, Stanley, and Fitzgerald study back in 1965, we know that there is no apical periodontitis. Basically, there's no apical infection that results from that. So that's good to know. We need to remove bacteria, and when we remove it, we need to clean and shape. So we use our hand instruments, our rotary instruments, and chemomechanical cleaning, such as irrigation with bleach or sodium hypochlorite and other irrigants. But we know that we can't possibly clean everything. We're not sterilizing the tooth. We're not taking the tooth out and putting it in a sterilizer. We can't clean everything, and we also can't touch all of the walls of the root canal system with instruments. In fact, we know from a study in 2001 that's quoted often that about 35% of the walls of the root canal system go untouched. And that's because root canals are not simple cones like an ice cream cone. They are much more complex, and they have little webs and isthmuses where bacteria can hide. So we want to do our best to remove bacteria from all of these places, but we know we can't possibly do all of it. So our next goal is to prevent future recontamination of root canals. That purpose is to seal against future bacteria from coming in, but anything that's remaining, we want to entomb it. We basically want to block it off so that that bacteria has no ability to flourish or multiply. And then we want to prevent any stagnant fluid from serving as nutrient source for future bacteria and infection. So you can see in this particular case, there was a lateral canal exiting on the distal of this tooth. And if that wasn't cleaned and then filled, that could become a source of future infection. So other reasons why it's important to obturate root canals is that it fills the space that was previously occupied by the pulp. That's important structurally. And then the gutta percha core actually acts as a piston. It pushes the flowable sealer into all of these spaces where bacteria could live in the future. And traditionally, when we've obturated, it's been really important that we maximize how much gutta percha we put into the canals. So we would try to put as many cones of gutta percha in there as possible and minimize the amount of sealer used. And that's because we know that many traditional sealers shrink, such as the resin-based sealers. These would be like AH sealer, AH plus, jet, or other resin-based sealers. They shrink. And then many sealers that have traditionally been used resorb. Those include ZOE, or zinc oxide eugenol. That's like your Roth sealer or pulp canal sealer. It tends to smell kind of nice because of the eugenol, which is oil of cloves. But those tend to resorb, as do the calcium hydroxide based sealers. So traditionally, we couldn't rely on the sealer because it might shrink or resorb, so we had to put as much gutta percha as possible into the canals. Now, with these common sealers, like I mentioned, resin-based, zinc oxide eugenol, and calcium hydroxide, the idea was that the sealer would just provide a seal to the root dentin to prevent microinfiltration of bacteria. However, you had to have very specific conditions for the sealer to work well. That included perfectly dry canals in order to have good adhesion, but that was pretty challenging to obtain clinically. So these sealers haven't worked perfectly, which is why there's been a desire to find something better. When we go to our third goal, in order to save teeth, the ultimate goal of endodontics is to eliminate and heal apical periodontitis or apical infection. And we know that the sealer is what actually comes into contact with not only dentin, but the periodontal tissues. So that includes the apical tissues. If there is a sinus tract and the sealer traces the sinus tract, it'll be in touch with gingiva and mucosa. It may be in touch with bone. It depends on the case, but the sealer is in touch with all of these other structures. So it's important that the sealer possess ideal material properties and that we think about the gutta percha as just being there to help push the sealer into the places it needs to go. So this is the one X-ray, which I put a little star here, that is not of BioRoot Flow. This was taken in the mid-2010s. It was one of the first root canals that I had done, and this is with a resin-based sealer. So what would ideal sealer be like? Basically, it would be something that the tissue could tolerate. It would be biocompatible. It wouldn't shrink when it sets, and also it would set. It would set slowly so that if you needed to adjust something, you could. It would be adhesive, so it would adhere well to the root canal walls. It would be visible on x-rays, so it's radio opaque. It would be bacteriostatic, so that it doesn't encourage bacterial growth. It wouldn't cause staining of the tooth structure. It would be soluble in common solvents so that if you needed to retreat the case, you could. But it would be insoluble in saliva and other oral tissues and fluids so that then the seal would remain. Now, in this case, this is a resin-based sealer. We know that resin-based sealers require perfectly dry conditions in order to set. Because this lateral lesion was oozing a little bit, even though I had sealer out here, this was taken immediately post-operatively. It's likely that this sealer that I placed here probably never set. I think this was 2016, and I unfortunately did not have the opportunity to follow up with this patient, but this sealer probably never set, and therefore it probably did wash out. In addition to that, resin-based sealer could cause a small foreign body reaction. Obviously, in this localized area, it could be irritating. And then in addition to that, it doesn't possess properties that help kill microbes. So any bacteria that was remaining out here, this excess sealer doesn't aid in the antimicrobial efforts. Basically, it's just kind of sitting there, not really helping with the healing. By contrast, this is a pre-op CBCT slice and then a post-op PA radiograph that I took of a case I did probably a year or two ago. Sort of similar with the lateral lesion and the lateral sealer puff, but this is with BioRoot Flow. So I feel that this is not going to wash out. This is also going to help aid the antimicrobial efforts, and it will not induce a foreign body reaction. Again, in our attempt to eliminate and heal apical infection, having a high pH is actually really beneficial. So calcium silicate sealers like BioRoot Flow do have a high pH. They're very alkaline or basic, which causes them to be antimicrobial. They're also bioactive, stimulating that apical bone to heal again. And part of this is because BioRoot Flow is a tricalcium silicate sealer. It actually has the highest concentration of tricalcium silicate on the market at 36%. And that allows for calcium release, which then aids healing of the apical periodontium. There are many other competitors on the market. However, a lot of them have a lower concentration of tricalcium silicate, and they may also use dicalcium silicate, which creates a longer setting time, making it more prone to washout as well. Part of the reason why having tricalcium silicate is so helpful is you can see having tricalcium silicate, say 2 molecules of this tricalcium silicate can lead to 3 units of calcium hydroxide release, whereas 2 molecules of dicalcium silicate only yields 1 molecule of calcium hydroxide release. And that's because of this particular hydration reaction. So it's not a 1-to-1 ratio where if you have, dicalcium silicate, you get 2 units of calcium hydroxide. And if you have tricalcium silicate, you get 3 units of calcium hydroxide. It doesn't follow linearly. So having tricalcium silicate is significantly more beneficial than dicalcium silicate, which is why BioRoot Flow is based on that molecular structure. And then that release of calcium hydroxide, those hydroxyl ions, the OH negative ions, increase that pH environment and provide those antimicrobial properties. You can eventually then have apatite precursors and hydroxyapatite precipitation onto the surface of the material, which yields that really good apical bone healing. So what makes BioRoot Flow unique? Well, we know that it does set to create a fluid tight seal. One thing that's nice about it is with its viscosity, it is a little bit thicker than some sealers on the market. This actually helps it to set better, and it helps it to set without washing out. Sealers that are a little bit too thin, in my experience and in the experience of many of my colleagues, sometimes will wash out before they have the opportunity to set because they're starting from such a liquid state that they don't have the opportunity to fully harden before the apical fluids have taken them away. Also, BioRoot Flow is radio opaque, and you can see all of my x-rays that show its radio opacity, so they provide a good visual. and a good reference. But basically, the radial opacity is such that it doesn't hide your voids, but it also shows you exactly what you need. So it's kind of that happy middle ground. It slightly expands upon setting. It does not shrink. It does not cause coronal discoloration. It has a high pH, which makes it antimicrobial. The setting time is favorable, so it's not too long, not too short. Again, if setting time takes too long, like I said, it can wash out in the meantime. It doesn't wash away easily. It's hydrophilic, meaning that you don't need to have perfectly dry canals in order for it to set. It induces bone growth and it's biocompatible, and it has a high purity without contaminants. So we're seeing a shift in all of endodontics from using as much gutta percha as possible because you couldn't rely on your sealer to now shifting to sealers where we want to use more of it because the sealer actually has benefits and we want it to be able to work its magic. So the more sealer, the better, basically. We're also seeing shifts in terms of restorative materials from being completely inert and just filling up space to being things that are bioactive. So a good example would be like shifting from amalgam, which is essentially inert in terms of what it does for the tooth, to bioactive restorations such as biodentin. So we're seeing this shift all throughout dentistry where we're trying to improve our materials. Because of this, we're seeing changes in the way we obturate root canals. So I teach at the University of Minnesota School of Dentistry, and obviously I went to dental school as well, as did you all. So you know that you were taught probably to maximize the amount of gutta percha, minimize the amount of sealer, and that's because you couldn't rely on the sealer. So there were many different techniques you could use. Single cone techniques without a calcium silicate or without a bioceramic sealer, they didn't provide a very good seal, and that's because the sealer wasn't reliable. It was probably resin-based, and it wouldn't set if it wasn't perfectly dry, or it was zinc oxide, and it wouldn't, it wouldn't stay, it would resorb. Cold lateral compaction, you might have done that to try to maximize the amount of gutta percha. So you'd put all these cones in laterally, which created a better seal, and it was very cost effective, but it was technically challenging and not very fast. And then warm vertical compaction had become quite popular. And that's because it would provide a good seal, but it was fairly costly, not particularly easy and not particularly quick. And again, all of these came out of necessity because sealer couldn't be relied upon. Now with bioceramic, otherwise known as hydraulic or calcium silicate sealers, such as BioRoot Flow, you can actually have a simplified single cone technique, but you actually get a good seal because you can rely upon your sealer. So we see this huge change in endodontics, and the American Association of Endodontists has a couple of really good publications about this. One of them here is by Drs. Coley and Karabuchak about bioceramic usage in endodontics, and they basically show the difference between how we used to obturate, having as much gutta percha as possible in a cross-sectional view, very little sealer, versus how we're obturating now, recognizing that root canals are not perfectly round, they have a lot of complexity, and that we would like to put sealer in all of these nooks, crannies, all of these isthmuses, and we just use the gutta percha as a piston to push the sealer, and it also serves as a pathway for future retreatment. So this is where we're going in our field. This is another view as well. We're trying to maximize sealer in all these areas, and gutta percha is just there to help push that sealer. So BioRoot Flow sealer is indicated for permanent root canal filling in combination with gutta percha points. It is easy to use, so the syringe is nice because your staff don't need to mix the sealer, and then you know you're going to have the same consistency every time, and you can use it with either warm or cold obturation techniques. So if you prefer to still do a warm backfill, you certainly could with this. It's also highly pure calcium silicate, and it is resin-free, so that's going to allow for no shrinkage and limited bacterial growth and improved biocompatibility. And like I mentioned, it does flow into those accessory canals or lateral canals. It provides tight adhesion to dentin and gutta percha, and it gives reproducible results in a variety of cases. So the way it comes in the box, it comes with a finger grip, which is nice. So depending on the size of your hand, you may like having this on there. So that can go onto your syringe, has a little cap, and then it comes with lure lock syringe tips. And then in the box, there's also a pouch to prevent humidity from getting into the syringe. One of the benefits, so all the benefits I'm going to talk about are things that I believe are benefits of this. So when you use the sealer, you may find additional benefits as well, but from my experience, these are the things that I think are important. So one of the benefits is purity. I like the fact that Septidont uses a proprietary in-house manufacturing process, and that they're not having impurities that could cause harm to our patients in their sealer. So there are many manufacturers that use Portland cement where they're unable to remove impurities from their sealer. This can cause a variety of issues, including staining teeth, can cause difficulty with handling as well. I also like that by having a sealer-based obturation technique, I don't need to plan my instrumentation based on how I'm going to get as much gutta percha in as possible. So traditionally, if a root canal was minimally tapered, you would need to still taper it with your instruments in order to be able to fit so much gutta percha into it. Now you can be much more conservative because you're relying on the sealer rather than maximizing gutta percha. This may actually help prevent vertical root fractures and allows us to be minimally invasive and allow teeth to last much longer. Post-operative discomfort also seems to be improved because, like I mentioned, some sealers can have a foreign body reaction and they can be not biocompatible. So that cytotoxicity can cause discomfort for patients. Of course, if you were to extrude any sealer, no matter how biocompatible it is, if you extrude a lot, yes, it's going to be uncomfortable. But small sealer puffs, small extrusions, unintentional apical extrusion of a calcium silicate sealer like BioRoot Flow leads to very minimal postoperative discomfort. So in the case of my mother, who had a very bad toothache, you barely even touched her tooth and she wanted to yell. Right afterward, no pain. So now every patient is different, but I will say that my patients have not had an issue that has concerned me with postoperative discomfort with BioRoot Flow. I also like that this provides a simplified technique, and there are a lot of providers who are starting to use a calcium silicate sealer-based obturation, basically making the sealer the focus rather than gutta percha being the focus. So it's about 60% of providers or dentists worldwide now are starting to do that. And I like that because I'm able to get good outcomes, but I'm able to usually use a single cone technique as long as I use a tapered gutta percha cone and as long as I modify it as needed, which we'll talk about a little bit more in the presentation. I also like that it's simple for team members because they don't have to mix the sealer, and sometimes there's difficulty with that, with mixing too much of one ingredient, not enough of the other, or mixing it too early and it starts to dry. There's a lot of factors when it comes to hand mixing. So having something that is syringeable is definitely beneficial, and you can apply it directly into the canals. So I do like that. I also like that it works for warm or cold techniques. So if I typically use cold techniques. So typically a single cone sealer-based obturation, but if I want to use a warm technique, I can as well, and that's not an issue with BioRoot Flow. And we know that there's going to be good results regardless of whether it's a cold or a warm technique. So there doesn't seem to really be a difference in the long-term outcome. I also like that this is built on Biodentin because that's a product that I trust. So I know that these products from Septidont have excellent biocompatibility due to their similarity with biological materials like hydroxyapatite. And I know that bioceramics can regenerate the tissues, and that's what I'm looking for as an endodontist. Another benefit that I like is the viscosity. Like I mentioned, it may be counterintuitive, but something that is less viscous actually causes more voids. So something that's less viscous is very thin. Think like water, whereas something that's more viscous may be like honey. It's thicker. So something that is thicker or more viscous actually leads to fewer voids. And that's because that material is a little bit more robust. It also seems to hug the gutta percha cone as I place the gutta percha cone down. And some of these studies were done on the precursor of BioRoot Flow, which was BioRoot RCS. It's a hand mixed material, also a wonderful sealing material, and I've used it as well for obturation. But there were some providers who were adding more liquid and less powder to try to thin out the sealer. It turns out when you do things like that, when you thin out your sealer, you make it more runny, more watery, you actually get more air bubbles and more voids. So having BioRoot Flow be a little bit of a thicker mix actually leads to fewer voids, which is definitely beneficial in endodontics because we don't want voids for bacteria to be able to live in. In addition to that, I like that it flows where I want it to. So this root canal, and I'm recording this in July, by the way, this root canal I did 3 days ago. So I like that it flows where I want it to. So this patient came in with the lower right second molar that was necrotic, and I don't have a CBCT slice to show you here, but the distal root is directly on the mandibular canal, which houses the inferior alveolar nerve. So this is a case where if I were to extrude a significant amount of sealer, it could be detrimental, cause paresthesia or anesthesia. So when I obturated this case, I wanted to make sure, and again, it was necrotic, so I need to seal it well. It's very important that I seal it well. And again, I want to kill bacteria, so I want some sealer down there to provide that antimicrobial effect beyond when the patient is in the chair. So I do want my sealer down there. I don't want to avoid getting it down there. I just don't want it into the inferior alveolar nerve. So I need it to go exactly where I want it, not shorter, not longer. It needs to be right there. And so when I did this case 3 days ago, I made sure that my assistant gave me BioRoot Flow because it does seem to flow exactly where I want it to. I also find it easier for pulp chamber cleanup. It doesn't just go everywhere in the pulp chamber and get stuck places. It flows a little bit, but I do find that the sealer cleanup is easier than with thinner or more runny sealers. So let me show you how this turned out. I took 2 angled final x-rays. So here's one. You can see the sealer kind of just gently kind of going up, but not extruding into the mandibular canal. And same thing here as well. So here is the mandibular canal, but here is the apical lesion. So if I were to have filled the entire apical lesion with sealer, you know, some of that could go into the mandibular canal, and that would concern me. You can see I got it exactly where I want it, but it didn't go further, it didn't go shorter. It went where I wanted it to, and that's something that I really like. So I want to talk about predictable obturation and techniques for that. So in an ideal world, we would always be able to fill these little lateral canals. You know, if there's something that's intricate, we would be able to seal it. And that is certainly one of the goals of endodontics. But we know that teeth are not simple. So the first thing we need to do for predictable obturation is to assess the radiographs. We need to really look at them. So I do take a CBCT, limited field of view, usually only a few teeth, very small area. I will take a CBCT of almost every case before I perform endodontic treatment, and that is for good reason. The reason is I want to know what I need to do, what the tooth needs, because not every tooth is the same. So you can see both of these are CBCT slices, but a case like this, oh my goodness, I think I ended up finishing on a 2002 or maybe a 2502 file. And so then that informed the way that I irrigated it informed the way I obturated. It affected a lot about the way I treated this case. Similar here, I wanted to minimize taper because I don't want to create a strip perforation here or here. And I'm also right on the sinus, right? So I don't want to be extruding into that. So we need to really closely assess the radiograph to decide what we're going to do. When I take a master cone radiograph, I'm trying in my gutta percha to see how it fits. I like to measure my gutta percha with locking cotton pliers. I put the gutta percha into length. So let's say my length is 20 millimeters. I measure to 20 millimeters, grab it, put it in, let go, and then push. See if the gutta percha goes further. If it goes further, you need to then grab again with your locking cotton pliers, measure. Oh, it's 21 millimeters now. Cut the tip of the gutta percha off, have it be 20 again, put it in, let go, push. See if you can get it to go long, because if it goes long, you know when you obturate, it's going to go long. If it doesn't go long enough, then you also have a problem. So you want to be sure that your length is exactly where you want it. So it's not too short, it's not too long, and the locking cotton pliers are very helpful for that. I like to use a tapered gutta percha. So it's important that our gutta percha not be too thin. It needs to have some kind of a taper. Otherwise, this isn't going to work very well. And then I use scissors commonly, so sterilized patient scissors to cut the tip of the gutta percha so that I have customized the size. Like I mentioned, locking cotton pliers are really critical so that they can grab the gutta percha at the exact length that you want. When I use my paper points, it's important that we leave some moisture, just some, in the canals so that the sealer can set, remembering that this is a hydrophilic sealer. So when I put paper points in, obviously if the paper point is very wet, I need to continue on. But if I notice my first paper point is like this, the second one is like this, I'm going to stop after that because you know that you have now wicked up that much moisture and there's probably a tiny bit remaining. That's fine. You don't want it to be completely bone dry because otherwise it makes it challenging for calcium silicate or bioceramic sealers to fully set. Remember also that a small amount of blood is okay, a small amount. It contains phosphates, which help with the setting process, and fresh, clean blood is clean. Humidity and moisture are important to think about as well. So the kit does come with a pouch for the BioRoot Flow, and that prevents humidity from getting in and setting the sealer. And again, the cap as well, you want to leave that on between appointments. And this is true for any calcium silicate or bioceramic sealer. We know that they will set if they're in the presence of moisture, which is also in the air. With the Lure-Lock syringe tip, I usually use the tip that is included with the kit. What I like to do, because obviously it's straight, I like to kind of pull on it and almost curl it like you're curling ribbon for a gift. So I pull on it and the heat from my hand kind of warms it up and makes it a little bit stretchy. I kind of pull and I curl. So you don't want to kink it because otherwise it's like a hose, like a garden hose, then it won't flow, right? Because it's kinked. So you want to have a very gentle curvature, and that gentle curve will allow you to easily get the tip into the tooth and get it into the canal. But if you decide that you don't like that tip, or you for some reason need a different tip for a specific case, it is a universal lure lock. So you could use a different one. These are just some images that I found online, but you could attach a different lure lock tip as well. So it is universal and interchangeable. I like to curve and curl the tip, and then it's important to pre-extrude. So you don't want to just extrude into the tooth immediately, because if you have a lot of pressure, if you're pushing too hard, you could end up extruding out into the mandibular canal, mental frame, and anywhere. So that's true for any kind of an injection technique. You want to pre-extrude so that you know that the material is already flowing. I'll usually do that onto my glove, make sure a tiny bit comes out, and then when I put it into the canal, I will inject and I will pull back as I'm injecting. Then I take the tip off and I dip my gutta percha with my locking cotton pliers. I actually dip it into the hub. So I put my gutta percha into a hub just like this, and that allows my gutta percha to have extra sealer on it. So in terms of sealer placement, the best ways to have a good result and a well-sealed root canal system is to inject or to use a Lenschelot spiral. So either of those. You could also use sonic or ultrasonic to agitate and get sealer in there, or you could also use a file or a paper point. But your best bet is going to be using one of these techniques. In terms of radiographs, I also think it's important to take a master cone radiograph with no sealer, but then to take one with gutta percha cones and sealer in it. That way you have an opportunity to customize. So if you're doing a sealer-based obturation technique and you know you have something complex, if I take this radiograph, which is with my gutta percha and sealer together, and if I see that there's no sealer here, then I would say, okay, you know what? Let me take out the cone again, put some more sealer in, and then put my gutta percha back in again. I also see a small void here. That tells me that I have a very oval-shaped root canal system. So I see these things, and this actually helps me decide how to obturate better by taking a gutta percha plus sealer x-ray. I know, okay, that's already taken care of, good to go, check that off the list. But I see this small void here. I may add a lateral cone. I may compact more. I may use a warm backfill. I will do something to try to fill that void. So this gives me a lot of information. It's been very helpful. Other tips I have are to use plenty of sealer. So you don't just put the tiniest bit in there. I know providers who do that. They put the smallest amount of a calcium silicate sealer in the canal and then mostly gutta percha. That completely defeats the purpose. The whole point of using a calcium silicate like BioRoot Flow is to maximize its usage so that it can be antimicrobial, so that it can expand into those nooks and crannies and prevent bacterial infiltration. If you only use the tiniest amount and you barely smear it on there, it's like not using enough sunscreen. You're still going to get sunburnt. So you do need to use plenty of sealer. So that will ensure good apical adaptation as well. And we need to check that. We'll check that by pushing on our gutta percha master cones. We'll also check it with our radiographs. Taking that cones and sealer radiograph is helpful. Making sure you have enough taper to your gutta percha is really important. If you use minimally tapered gutta percha, you may have difficulty with a single cone technique. And then compacting at the orifice level. So really making sure to sear down and give it a good push. So that helps. This was a case that I had done probably 2 or 3 years ago. And this premolar, you could see this lesion. It was actually on the palatal aspect. There's this lateral canal here. So this is my post-operative x-ray, immediate post-op. You can see my little puff of BioRoot Flow sealer. And then I took a low resolution CBCT. So that's why this is more blurry than that. This is a low resolution just to check it. Make sure that that puff was truly into the lesion and not somewhere else. So I knew, okay, yes, I got that area sealed well. And that's because I used enough sealer. So we know in terms of success, there is very favorable clinical success of BioRoot Flow. BioRoot RCS, of course, is also very clinically successful. And Dr. Shimon will be talking about that, but 91% clinical success after 2 years. So I want to show you some of my cases as well so that you can see some of my successful results. I do want to mention, it may be the same in your practices as well, but for me, most of my patients come back at 6 months. But for a lot of people, if they don't have pain, they just don't ever come back. And if they're healing well at 6 months, they don't come back again. So a lot of my follow-ups are 6 months to a year, but usually after that, most people don't come back. So I will show you some of my cases for your reference, but just recognizing that I really don't have 2-year follow-ups, even though I've been seeing patients and using BioRoot Flow for well over 2 years. Been using it since the end of 2021. So here's that case that I just showed you. That was that pre-op CBCT view with that palatal lesion, lateral canal here. And then this was 6 months later when I saw her. So that whole area had healed. This was a case that I did just recently. I actually repaired this resorption with biodentin. So this is biodentin down in here, but you can see this was immediate post-operative CBCT. Yes, I know he has some sinus issues, and he is seeing a physician about that. But he had all of this apical bone loss because of necrotic pulp. There was resorption here that I repaired with biodentins. This is immediate post-op, and this was 6 months. And you can see the sinus floor has regenerated as well. Another 6-month case, you can see lateral and apical radiolucencies. Now the patient has their crown, and that has all healed. Another case that was similar, lateral radiolucency, healing very well at the 6-month mark. This is my immediate post-operative, but 6 months later, it's looking really good. This patient just came in the other day. She had actually had another tooth that was bothering her, and so I took the opportunity for an 11-month follow-up. When I first saw her 11 months ago, it was a temporary crown on this molar. Performed the root canal treatment, and now she has her crown and she's doing well. Obviously, the zygomatic process and the sinus are here, so it's hard to see the apical tissues. So I wanted to show you a couple of CBCT slices from 11 months. You can see MB2, MB1s. This is the MB root, and then the DB and the palatal. So the apical tissues are looking good. At the 12-month mark, I have a retreatment case to share with you. So large apical lesions here, that's a CBCT view of that. So I performed this retreatment. This is the immediate post-op. So you can see a little bit of sealer into those lesions during that appointment. And then this was 12 months later, really good healing. And I have a few CBCT views as well. This is the mesial root. So there was a missed middle mesial, and then there was also another exit point here. Nice apical lesion. That was the preoperative, and then this is at 12 months. And then here's the distal root. There was a missed distolingual canal apical lesion. I was able to fill the distolingual, refill the distal buccal, and then we have full apical healing at 12 months of that distal root. And the final case that I'll share with you today is a 15-month follow-up, and this is a molar root canal. You can actually see a little bit of resorption here. This was actually in early 2022, so this was in the first few months of me using BioRoot Flow. But there's some resorption here, and there was a large apical lesion here. This patient had been an emergency patient. So she came in. It was a 2-appointment root canal. But you can see once I finished, this is immediate post-operative. Of course, the lesion is there. I sealed that resorption, repaired it with biodentin. So that's all biodentin. And I obturated with BioRoot Flow. And then at 15 months, it is well healed. You can follow the lamina dura and the periodontal ligament space. And then here's some of the CBCT views. So that's pre-op. You can see that resorption. And then post-op. That has healed really well. And then the biodentin looks just like dentin. So there you go. But yeah, that went really well. So at the 15-month mark, she's doing great. So I hope that was helpful, providing my experience as a clinician, and I do welcome your questions.
Good morning, good afternoon, good evening. I don't know wherever you are. Finally, welcome to this webinar. I am Stéphane Simon. I am a professor in endodontics and oral biology, and I used to be a professor at the University of Paris, and then I quit it a few years ago. And now I'm back to my private practice, and I'm still a teacher and doing some clinical research on very specific projects. So in this webinar of 20-25 minutes, I'm going to share with you some results we recently provided for a clinical research to compare the BioRoot and the BioRoot Flow and to see if there is any difference in terms of outcome. But behind this research, which was a comparative analysis, but behind this, I was definitely also interested to see if using a bioceramics with a single cone technique is a predictable and reliable technique in every hands. So before to start this presentation, let me tell you that I do not have any conflict of interest regarding this product. So I don't have any money back for any feedback money regarding the sale of the products. But I have also to declare that I am the principal investigator of this clinical research. I say I am and not I was because this research is still ongoing, because after 2 years recall, the results were so interesting that Septodon has decided to continue to pursue this research with a 5 years recall. So that's why we are still doing some recall, and today I'm going to present you the 2 years recall results. So regarding the filling and the obturation, I just come back to these ESE S3 guidelines. I'm pretty sure you know them. If you don't know them, just go and Google and ask for the PDF, which is free for download. And it's very interesting because the previous guidelines were published in 1996, and though the ESE has decided to provide new guidelines on different topics, the objective was to provide some guidelines based on the literature. And if you read these guidelines in every topic, instrumentation, irrigation, whatever, you see that the research behind this is quite poor. And finally, as a scientific organization, it's very, very difficult for them to provide some guidelines. But what is interesting in the guidelines regarding obturation is that you can see that the root canal filling with good absorption in combination with any of the included sealers, epoxy resin, Zoe, and calcium silicate. That's the first time we can see the calcium silicate coming in some guidelines. So they don't say how to use it as a sealer to seal the cone behind themselves, or to use it as a filler. I just pour it into the root canal, you fill it, and then you get a single cone. So, but one of these, actually, they say that it's in the guideline, you can use a calcium silicate. So that was a good point. All the techniques we use today to fill a root canal, all of them are based on using good pressure as a filler and a sealer, whatever it is, zinc oxide or epoxy resin. This sealer is here to seal the cone, to make a sealing between the gutta perca point and the dentinal wall, because the gutta perca, it doesn't stick on the wall, and then we need a sealer to do the connection between both. And we know that the sealer is a very weakening point. So the only thing which is going to be infected in the root canal, that's the sealer. And that's why we need a maximum of gutta perca and a minimum of sealer, thickness of sealer. And that was a single cone with a zinc oxide sealer is not reliable, because there is too much sealer, which is not a filler, and that's very important, these two words, filler and sealer. So the sealer is dedicated to disappear, and then the more sealer you've got, the highest risk of reinfection you have in the root canal. So that's why the root canal filling based on gutta percha, you have to get a maximum of gutta percha and a minimum of sealer. So what are they talking about? So you can see here that with whatever the anatomy of the tooth is, that you can see here on this premolar, it's a very complicated anatomy. So not complicated, but not the normal anatomy. And it's a young patient. And then when you fill the root canal after the disinfection, and you maintain the disinfection ongoing, so the apical lesion disappear. We know that. We know that the problem is an infection problem, and then the consequence is inflammatory, and then removing the infection, you get the healing. And what is interesting is that even if your technique is not very accurate, so even if you don't reach, sorry, I would prefer to do that, even if you don't reach the final goal, meaning taper preparation, very, very nice obturation, if you disinfect it and you maintain this, you get a healing. So I completed this case. I'm not very proud of it, but I was not able to find the patency of the canal, of the major longus canal. But whatever I used a lot of stuff for disinfection, and finally I was able to get a healing of the apical lesion. The game changer of endodontics, that the evolution of endodontics is moving to a less invasive techniques. We know that if you want to use a warm compaction, you have to get a nice taper, minimum 6%. And then we remove a lot of dentin just to be able to fill the root canal with this technique. And somewhere, it doesn't make sense to say, okay, I'm going to fragilize my tooth only because I want to use this technique of root canal filling. If you do a retreatment, the question is completely different. Why? Because the tooth is already enlarged. The canal is already enlarged. So you don't fragilize too much the tooth if you retreat the tooth. But for an initial root canal treatment, where the canal is free of everything, does it make sense to remove dentin just for fitting with the recommendation of the root canal filling technique? So that's what we have to talk about. Because the evolution technique, look at this guy, Steve Buchanan, who everybody knows him. And I remember when I was a young dentist, he was pushing the GT5. The GT5 was a 12% taper. And actually, Steve Buchanan is selling some the mini cuts which are 3% taper at the tip. So what is interesting is that finally, even the people who were Schindlerians in their mind are moving to this less invasive with less preparation of the root canal filling, of the root canal. And there is something which, so of course it makes sense, but there are some limitations. Can we disinfect the root canal and can we fill it? So I'm not going to talk about the disinfection, but these disinfection techniques must be revisited, and the filling techniques as well. And that's why the bioceramic is interesting, because it can fit with a less than 6% taper preparation. So the concept of using a bioceramic filling is to consider the bioceramics or the hydraulic cements, whatever the word you want to call them, as a filling material. You are going to fill the root canal to obturate it with something you are going to inject inside. It's not a sealer. Of course, it's a sealer somewhere, but it has not to be used as a sealer. And I want to be very clear with this. And that's why the BioRoot RCS, root canal sealer, for me, it's a mistake. Because it's not a sealer. It should have been BioRoot RCF, root canal filler. The good apical point we're going to use must be considered as a carrier to push the material in the apical third, and eventually to retreat the tooth if we have to do a retreatment or if we want to place a post. Because the bioceramics would be very hard, so you won't be able to go through if you have to remove it for the retreatment of the tooth. But also, if you want to place a post, you have to remove at least 1/3 or half of the root canal filling material, and then you need the good pressure just for that. So finally, the technique is a single cone technique, but the philosophy behind this has nothing to say. I'm filling with the material and I'm using a good pressure point just for the techniques. If I want to fill a root canal only with the bioceramics, there is no problem. So what are the questions? So for me, it's an evidence because I'm using this for 12 years now. And the question is that, is this technique reliable and predictable? The second question is that, do we have clinical evidence of this effectiveness of this technique? Do the products influence the outcome? So we have many products on the market. It's that, all the bioceramics provide the same results? And then does the carrier influence, the carrier is not a good apical point. So the carrier is something we add to, the company adds to the material to make it like a flowable, putty, you can inject it, or sometimes like the BioRoot, you have to mix powder and liquid. So now with the BioRoot Flow, you are going to inject the material inside the root canal. So you need to add some carrier to make it like a creamy. And is it science or purely marketing? That's a big question, because finally, it's like everything, everybody remember the resilient problem. So where the marketing comes through, and they say that's the best technique. A lot of speakers giving lectures all over the world, and then 2 years later, the results were catastrophic. So we still have this in our mind, and that's why a lot of people are they are not very happy to see something new, different, something new coming, and that's why the bioceramic story is a little bit complicated for a lot of people. So the state of the clinical science. When you look about the papers published, finally, it's not only for the bioceramic, but in average in endodontics. But this slide is focused on the bioceramics and the BioRoot. When you look about the outcome, there are more case series, very small, very few retrospective study, very few prospective study. So the power of the science behind this is not very, very high. And for me, not sufficient to say, okay, there is a scientific evidence that this product and technique is good. Actually, when you look about what are the experimentation going on, very few of them. So you can go on the website, and some of them are comparing AH plus BioRoot or MTF Electrix, AH plus Endosil NT and the sequence, etc., etc. But a lot of very few, not a lot, but very few experimentation are still ongoing for recruitment. But now, 2 years later, they are still recruiting, and I'm not sure that they will go further. So what was the problem of the BioRoot RCS, except in the name of RCS? What was the problem? The limitation was to use a powder and liquid, and sorry, it doesn't work. So we had to mix the powder and the liquid, and finally this mixing was first, it was not very, the nurses were not very happy. All of you remember the 5 drops, big drops, small drops. So the mix of the products was not always the best one and the more creamy one. So sometimes it was too liquid, sometimes it was too hard. So there was something very complicated to manipulate this product. So that's why Septodon decided to provide a ready-to-be-used product. So the BioRoot Flow is exactly the same products on the paper than BioRoot, but they add a carrier to make it creamy and ready to be used as an injectable material inside the root canal. So for me, it will be complete. So sometimes I don't call it BioRoot Flow because I've called him the PA1704 for 3 years during the experimentation. So I have to be very careful. So the BioRoot Flow is a commercial name of this product. It's exactly the same than the BioRoot, but you don't have to mix it. It's a syringe, and you are going to inject it inside the root canal directly, and also always at a single cone of gutta-perca. So what is this experimentation I'm talking about? Initially, the objective was to collect clinical performance and safety on the use of BioRoot Flow, because this product is ready to be launched on the market for years, and it was launched in the United States more than 16 years or 18 months, sorry, not years, months, sorry. And it was not available in Europe. Why? Because it's an injectable, it's a class 3 medical product, and then as a clinical 3, the regulation asks for clinical experimentation with a randomized clinical, and then they ask the company to provide results that first the problem is safe, the product is safe, and secondly that it's a good product, at least not as good as the one already on the market. So the sponsor was Septodon, and still is. The CRO was SLB Pharma in Rennes, a very nice team. If you want to do some clinical research, I will recommend them because they are very, very cool, very nice team, very accurate. So congratulations to them. And I was the principal investigator coordinating a team of 13 investigators on 7 sites, so in France and Belgium. But what's interesting is that we mix endodontists and general practitioners as well. So all the treatment were not completed only by endodontists. And for me, it's very important. Why? Because most of the endodontists, they are very happy and very accurate with the warm compaction. So finally, I think that in the hand of an endodontist, everything works. So what I was interested in that to see that if with the GP, which is not very happy with endodontics but want to do the best as he can, is this material working well? And having this mixed team, we will be able in the future to compare the results of the endodontist and the results of the GPs. Of course, everything is not based on the material. I'm aware about that, like you. But if at the end we have similar results between endodontist and GP, that asks a very nice question. So we didn't ask the GPs to do the endodontics in a very specific manner. So we just asked them to use the rubber dam in every cases to be able to not to include some very calcified canal with complicated anatomy, and that's it. So they can use the files they want, they can use the irrigation technique they want, like the endodontist, some use reciprocating, others use rotary files, and finally, I didn't care about that. The only thing is, okay, you have to use a rubber dam. You can use a microscope or not. If you don't have any microscope, it was not a requirement for this experimentation. So here are the name of the people who were in charge of coordinating the team on site, and then we had 13 investigators. So the study design was that we included 160 patients. So the alpha risk was calculated before, and then because it was randomized by, we wanted to randomize the cases between BioRoot and BioRoot Flow. And then we had 160 patients, and then the system was settled for having 80 patients for the BioRoot Flow and 80 patients for the BioRoot RCS. And at the end, we had we completed the treatment. Visit 1, visit 2, we checked the coronal restoration and the visit. We called the patient at 1 week, and that's to see that if they had pain, and then we evaluated the pain, the discomfort, if they had to take pills, etc., etc. After 6 months, we had a first recall, and so just because we wanted to see the evolution, but also we wanted to be sure that the tooth was being restored with the coronal restoration. And after that, we had a visit 4 at 12 months, visit 5 at 2 years recall, and now we have the visit 6 at 3.5 years, and the visit 7 which will be at 5 years, and it's going to close the experimentation. What is important is that visit 6 and visit 7 are only ongoing for patients who received the BioRoot Flow. We are not recording the patient who received the treatment of the BioRoot RCS. So there are a lot of inclusion criteria and exclusion criteria, like every clinical research. I'm not going too deep inside, but we just asked the GPs at least to exclude the root canal treatment on tooth with a calcified canal and with a suspected perforation, because we didn't want to modify the outcome just because the preoperative conditions. So the chart flow, you can see that patients were allocated, and then we started the first inclusion on the 6th of November 2020, just after the COVID lockdown, and we completed the last inclusion of 160 patients on the 26th of June. And what is interesting that we had a very, very nice follow-up rate, because at 24, 85% of the patients had been recalled. So after that, we had plenty of data that we're still analyzing. So we had 50% of male and female. We had we made a difference between root canal treatment and retreatment, tooth with apical lesion or not, and the tooth type. So we had a majority of molars and premolars and very few incisors. So for the results, we provided to 2 calibrated endodontists with a kappa coin at 0.79. I'm not going to explain this, but if you're interested, go in the literature and you will see how we provided. So we had 2 readers calibrated, and then we asked them for a first lecture. When they had disagreements, we asked them to do a second lecture of the X-ray where there was a disagreement, and then at the end, if finally they didn't merge, and then they still had the disagreement, we had a meeting together and we discussed the case for final rating. So for the 24 months results, we selected the loose criteria and the strict criteria. Like every research in endodontics, actually, the loose criteria were successful treatments plus uncertain. What we call uncertain, that was, for example, the apical lesion in the process of healing, and where the lesion didn't evaluate there through the healing, but didn't evaluate to the pathology. And the strict criteria were strict successful treatments only, and then that allowed us to evaluate the efficiency of the treatment. So safety analysis, we had only one SAE, but it was an SAE for pulmonary embolism, so it has nothing to see with the products. And so finally, all this data will be published. We also were interested in the postoperative pain. Do they have less or more postoperative pain with one product compared to the other one? And finally, there were very few difference, and the BioRoot Flow was a little bit lower. We had a lower number of postoperative pain, but it was not statistically significant. So very quickly, I give you this presentation, this data, because if you want all the data, I can speak about that for 3 years, but we don't have the time, especially for a webinar. So the success rate were 91%, or strict criteria 89%. So that's why you will have a lot of communication from Septodont telling that they have 91% of success. So the 91% is not the loose criteria here. That's the average of all the treatments, including retrainment, treatment, etc., etc. So here we are talking only on initial treatment. 91 compared to 89%. Remember, they are endodontists, but also GPs, and some of them were very young. So if you look about the literature, there are a lot of papers showing that a huge difference between the endodontists versus GPs. We didn't have such a difference in this experiment, and that's why we merged all the data. For the retreatment, it was close the same, a little bit less with 82.5, and with the strict criteria compared to the 89 to the previous one. But that's retreatment. We know that it's, the success rate of the retreatment is a little bit lower. But with the loose criteria, we have a 90% instead of 91 with the initial treatment. The teeth with apical lesion at the baseline, so we see that we have a 95 and 96. So this was surprising because it's a little bit lower, higher than the previous results. But just because we had we had less teeth with apical lesion, so the number of cases is lower. So if you have healing, you modify the success rate and the percentage of success just because you have lower cases. So it doesn't mean that's why we have to be very careful in comparing the results from one part to another one. And teeth without apical lesion, the baseline is a little bit lower. Why? Because we had more treatment, we had more teeth without apical lesion compared to the teeth with apical lesion. So the discussion is, okay, at the end, I remember my mentor told me many years ago, he said, Stéphane, we do not discuss results. The results are here. We can discuss the way we completed the research, if you want. I know how we did it. I know that it was very strict, and definitely it was a good experimentation. It's the first randomized clinical trial done with the bioceramics fillers. And for me, I'm very happy. Okay, for the material, that's no discussion. But also, I'm very happy that finally we have some data showing that a single coat technique with a bioceramic filler seems to be a reliable technique. So after that, we can discuss everything. Okay, it's only 160 cases, but how many research are done on 160 cases in endodontics in a randomized way? Very few of them. So that's interesting with this material because Remember, it's a class 3, and on my knowledge, it's the only one classified as a class 3 material. And then even if you have some extrusion of the material, like puff or big puff, it's not a problem because it has been tested and it's an implantable material. And as you know, it will disappear because the osteoclasts, they love silicate of calcium silicate. So, of course, do not fill all the lesion with the calcium silicate. But as a class 3 material, if you have an overfilling or an over extrusion, it's not a big matter. So, as I said to you in the beginning of this webinar, we have 3 more years of follow-up coming on. So we have actually we are completing the 3.5 years follow-up, and then we'll have the 5 years at the end of 2026. And to complete the results, it will be interesting. So my conclusion is that finally, at least me, I can consider that filling root canal with the BioRoot is a relevant technique. So it is the only randomized clinical trial completed on the evaluation of efficiency of this kind of material, and we can consider, or we have one step to say, okay, it's a reliable and predictable technique. Doesn't mean that it's the best technique and then we have to stop the work compaction. Absolutely not. If you can do and you are happy with the warm compaction, it doesn't make any sense to change your technique. But don't use this material as a sealer. It doesn't make sense, because with the warm compaction you need an oily material, so you need a pub canal sealer or whatever, something done for that. And the bioceramic, there's a lot of discussion, can you warm it or not? Okay, I think it's not a problem to warm it, but these products are not made for that. So why do you want to use a material not dedicated for this technique just to say I'm using bioceramic? If you want to use bioceramics, do them as a filler. If you want to keep warm compaction, vertical compaction, and I'm still keeping this for such cases, finally, do it with appropriate sealing. So we must keep in mind that filling is efficient as long as the previous stages of treatment were completed in the state of the art or objective. Okay. Of course, if you do not shape and then either disinfected the root canals, so the filling is not going to provide good results. But it's not because of the material, it's just because the treatment is not completed in the right way. So if you have already seen me in different occasions in the meeting, you know that I love this sentence of the three steps of innovation of Schopenhauer. So the first step is the new concept is always ridiculous. The second step is the concept is the aim of a strong fight. Actually, with the bioceramic, we're on the second step. And the third step of everything, it becomes an evidence. And hopefully it could become an evidence in a few years now. And so I hope I will see that, because I'm very confident in this kind of products. So can we consider the bioceramic filling as reliable and predictable? Based on this result, I would say yes. Do I still use a warm vertical compaction in my practice? Yes. If yes, when? Mostly for complicated retreatments, when I'm not able to clean completely the root canal surface, because the bioceramic has to be attached to the dentin. So if I see that I have some places of sealer that I cannot remove, and I'm pretty sure you understand what I mean, in that case I'm going to use a warm compaction, because I need something to come and fill, and then the bioceramic is not going to stick on the sealer or remaining sealer. Do I recommend to switch your filling technique? Absolutely not. Absolutely not. I'm not here to say what you have to do. I'm just here to share my experience and my point of view, and do just whatever you want with this. And probably you will need more lecture, more evidence if you want to move. And again, if you use a warm compaction, it's perfect. Don't switch to anything. The only thing is that if you use a cone sealer, a single cone with a sealer, I will encourage you to do something and to change your technique, because that's not a good technique. But if you use a thermocompaction, if you use a thermofill, if you use warm compaction, even if you use lateral coat condensation, that's good. These techniques provide good results. Are they as easy as a bioceramic filling? I'm not sure. It's you make your decision, but The aim of this webinar was to show you that now we have clinical evidence that if you do this, it works. Thank you very much for your attention and see you soon.
So welcome back, everyone. Thank you very much for following our webinar today, and we hope these lectures were interesting for you. We've received quite a few questions that I've noted, and I've noted them as they came, so I will address them depending on where you asked them, assuming that they're whether for Dr. Kunyuth or for Professor Simon. So let's start with the one that I received during your presentation, Dr. Kunyuth, if you're okay with that. So the first question was that you've mentioned that BioRoot Flow had a high purity. How was that different from other sealers that you can find on the market?
Well, it's interesting. So some sealers are based on MTA, or they are created with another active ingredient. So instead of synthesizing the calcium silicate and ensuring that only that active ingredient is created, some companies are using a different product, trying to rework it, reformulate it, and turn it into a sealer. So with that, there can be byproducts that were undesirable. There can be heavy metal contamination. There can be other additives in the product because they were sort of repurposing something else. So one thing that's really nice about BioRoot Flow and also BioRoot RCS is that the calcium silicate is synthesized by Septidont, and it's able to assure that it is a high purity. And I think that's really important without all the contamination from other byproducts. This is important because our patients are becoming increasingly knowledgeable and intellectual, and they want to know what is going in their bodies. So I think that the purity is a major point of importance for BioRoot.
Thank you very much. Another question was to know if it was interesting to use a lentulospiral filler for BioRoot Flow in a white canal.
Yeah, you definitely can. So when you think about sealer, I always tell students when I'm teaching at the University of Minnesota, I always think about the fact that the sealer can kind of strip off or come off of your gutta percha cone. So you want to make sure the sealer is actually delivered to the apical portion of each canal so you can inject it. You can use a small injection tip, like a 30 gauge injection needle. You can use a lentulo spiral. You can inject in the coronal third and then use a sonic activation device or an ultrasonic device. There's many different techniques, but lentulo spiral I've used a handful of times, maybe only on 5 or 10 cases. But the lentulo spiral I think is great as long as you feel comfortable with it, not using it around a curve and having it break. All of those things are important. But yeah, I think a lentulo is very reasonable to use.
If I can mention something, it just, you know, when we used the BioRoot RCS, so it was so difficult to place into the root canal that we had to find different techniques. So the lentil spiral, injection, tips. I think we tried everything. Using the spiral is great, but you have a high risk of inducing bubbles in it. So you have to be very careful. So it was a good point for the BioRoot RCS because the viscosity of the products was a little less liquid. So it was more difficult to push it in the apical thirds, and we need to push it. Now with the BioRoot Flow, when we notice that it's so flowable that you don't need to activate or to push it. The only pressure with the good upper point is enough to push the products in the apical direction. And in the presentation that we have in the clinical research, we had a lot of data. And then one of the observation we asked to the dentist to do is just to notice that there are some bubbles in the thickness of the root canal obturation. And we had with the BioRoot, normal BioRoot RCS, but we didn't have any with the BioRoot Flow. So that's interesting because the viscosity, the flowability of the BioRoot Flow is very easy to handle, make it very easy to handle, and I think the tip we use with the tips provided with the syringes are great. In my opinion, they are a little bit too tapered and too large. But you can use, as Lauren showed in the presentation, you can use some tips, 30 gauge or 35 gauge, for example, and just test it. And then with a very small tip, you can go up to 4 millimeters from the apex and the root canal, and just inject it, and it's enough.
Thank you very much. I think do you still hear me? I think, okay, I've lost you for a second. Sorry. Thank you very much for both your responses. And following that, a few questions actually popped up. So if maybe we should just follow up on that right now. So one was asking if we can pump the gutta percha initially to make it spread into lateral canal, or if it will extrude through the apex. And if it does, should you warn the patient for post-op pain?
That is a great question. So I think, from my perspective, when I'm trying to get the sealer down to the apex, so let's pretend I ran out of all of the tips for syringing it in. Let's say that I lost all of them, or I'm missing all of them. I don't have a Lentillo spiral. I don't have anything I can use to get it down. I would say you can take a sterile rotary file and you can coat it in the sealer, put it down and twist it the opposite way that the file would normally rotate, so counterclockwise, to try to spiral it in, almost like a do-it-yourself Lentillo spiral. You can also take a paper point and use that to pull down. The little fibers of the paper point will help kind of pull the sealer down, recognizing that the first time you put it in, it's going to absorb some sealer. But if you keep using that same paper point, it will eventually stop absorbing sealer and it will just help kind of pull gently sealer down. I am not a big fan or recommender of pumping the gutta percha, because I feel like rather than forcing the sealer into small lateral canals, it seems to just force it out the end of the root because that's easier. So I think that happens with all sealers. What I will say is with BioRoot Flow, I have much smaller sealer puffs and smaller extrusions than I do with other sealers on the market that are syringeable. Some of them are so thin and have very minimal viscosity that they just flow out the end of the root without hardly trying, and I get huge sealer puffs. In those cases, yes, I do warn the patient about potential postoperative pain. But if I have a small sealer puff with BioRoot Flow, I don't warn them. And also, if I have a small sealer puff into an apical lesion where there's already a hole in the bone, I also don't really mention anything about it because I'm not very concerned about it. I hope that's helpful.
Thank you. I don't know, Stefan, maybe you want. Yeah.
Yeah. So again, with the clinical research, we didn't notice any pain related to extrusion. We just need to be careful with what extrusion means. So the extrusion is just a little amount of sealer or filler of material going outside because the patency of the apical foramen. It's not like a huge amount of material, because this material is very basic. So if you have a lot of material, of course, it's going to create an irritation of the bone and then inflammation in pain. What we noticed also is that this exclusion of materials were disappeared very quickly in less than 12 months. Why? Because that's also a concern of the people, is that, okay, if it gets resolved in the bone, why it won't be resolved inside the root canal? Just the reason is very simple. In the bone, you got osteoclasts, and the osteoclasts, they love calcium and they love silicium. So they love the calcium silicate. So they're going to destroy this, but you don't have any osteoclasts inside the root canal. So they're not going into the root canal. But regarding the pain, if you, I went very quickly because the graph is such a mess, and And even me, I had a lot of difficulty to understand it. So it's very difficult to know if the pain after treatment are related to the material or are related because we did a root canal treatment. So, but we didn't notice any difference between BioRoot Flow and BioRoot. And then in the previous research that completed, has never been published for the reason why, because we had too few samples, we had only 50 or something like that. We compared BioRoot versus warm compaction, and in terms of pain, there were no difference. So I'm not sure there is a difference. There is more pain due to this material.
Thank you both. I have one more question that I think is more for, well, it's more for Stéphane Simon, Professor Stéphane Simon. The question is BioRoot Flow's success rate higher than other bioceramic? And why do you think it has such a high success rate?
I have no idea. It's just I have no idea if it's better or not compared to the other bioservices. The reason is that it has never been properly investigated. So what we can say with this experimentation, this clinical research, randomized clinical research, at the end, 91% of success. And I remind you, including GPs and endodontists, including treatment, retreatment, apical lesion, no apical lesion. So there are plenty of data. I don't know if it's better or not than another bioceramics. As long as nobody is going to test it, we will not reply on it. What is interesting is that when you look about the literature, there are very, very few publications on this topic. So we have what we call retrospective studies. We have some few comparisons like that, but the power of the science behind this is quite poor. But remember, evidence-based is not only literature. And then I am a reader, I am a writer, I've published 70 papers, but I'm also convinced that everything is not inside the literature. It's not because it's not inside the literature that it doesn't exist. Evidence-based is literature plus your experience plus the experience of your peers, and etc., etc. So if you look about that, it has never been shown that warm compaction provides better results than other techniques. There was the only one publication, the Toronto study, on phase 4, and they had to wait for at least 6 years to see a very, very small difference between lateral cold condensation and warm compaction. So that's the question is excellent because we don't have any proof to say that bioceramic is better than warm compaction or BioRoot is better than, I don't know, NeoSealer or whatever. The main difference of the BioRoot compared to the others, on my knowledge, BioRoot is the only class 3 material. It means that if you have an extrusion of the material, you will never be pursued to the quartz because that's an implantable material. All the others are class 2. It means that if you have an extrusion of the material and the patient has a pain, you are guilty because you are not allowed to place this material outside of the tooth. But so far, that's the only difference I can say today from this material to another one.
Thank you very much. I think we have time for one more question. So I've had a few questions about the moisture remaining in the tooth. So I will try to and make you answer all of them in one. So the question is that, so you both said that BioRoot Flow needs moisture to set. So the question is, how much should the canal be dried with the paper point, and where should the remaining water come from? Is it EDTA? Is it hypochlorite? Is it saline or water? Or
So there is not a clear-cut answer to this. A lot of this is based on experience, like Professor Shimon mentioned. Our experience often dictates what we do. So we know EDTA is hydrophobic. If you put it on your glove, you'll feel that it's very slippery, almost like an oil. So EDTA should not be the final rinse if you are going to, or the final irrigation if you are going to then use a calcium silicate sealer like BioRoot Flow, because it will not help with the setting. Something that is aqueous and hydrophilic, that is attracted to water or water-based would be ideal. So I usually finish on sodium hypochlorite as my final rinse. Some people will finish on saline. I've also heard of some people who will literally like dry the canals fully to ensure that everything is cleaned off, and then they will take a moist paper point. They will put it in sterile saline and then just put it gently into the canals. There are many different ways to do it. My preferred method is to do my normal irrigation. My second to the last or penultimate rinse is EDTA. My final rinse is sodium hypochlorite. And then I dry until my last paper point comes out with about 2 millimeters of moisture left on it. So I'm not waiting until they get fully dry because I want a little moisture remaining. And then I know there's also moisture in the dentinal tubules because they have an inherent humidity, kind of like our skin. And then I inject my sealer from there. I also think that because BioRoot Flow is a little bit more viscous than some of the other syringeable sealers, it seems to set better. It doesn't seem like it needs, from my experience, it doesn't seem like it needs quite as much moisture in order to harden as some others. I've used some competitor products that are very liquidy, very runny. You think something that's that liquidy needs a lot of impetus in order to set. I would imagine that those would need even more moisture than what I'm doing now.
Yeah, I don't have a lot to say on this because the thing is that we know that the bioceramics need water to set. And the problem is that nobody can tell you how it works. Nobody. Ask the engineer. Maybe they know, but and they don't want to share. They say, okay, you need water. Okay, where is the water coming from? I don't know. From the dentin? Yeah, 70% of water is inside the dentin. But in that case, do you create some constraint in the dentin if you aspirate the water? I don't know. To be honest, I don't know. What I noticed is that when you use this material on extracted teeth, because we did some experimentation, so the tooth is totally dried and the product is setting. So I don't know where the water is coming from. I have no idea. So it remembers something. It remind me when for the pub capping, the question was, do you have to disinfect the cavity before placing a biodentin or water? Anybody say yes. And what do you want to disinfect it with? Sodium hypochlorite. And then the people say, no, don't use sodium hypochlorite because you destroy the layer and then the bonding is not good. I say, okay, I'm going to use the chlorhexidine. No, it's worse. So what do you want me to do? I prefer the sodium hypochlorite. So at the end, you have the question on the paper. I've been doing some research for 20 years, so I get my question on the bench. But at the end, what do you want to do? So the only way for me to get an iterated teeth is to dry it as much as possible, and then you use a paper point with saline on it, and you're going to remoist it, at least the water on the walls, and then you provide some water for the product to set up. So if you want to, it makes more sense to dry it and then to undry it a little bit and you control it instead of, because, it's exactly what is difficult in teaching. We used to say dry it, but do not over dry. What does it mean? I don't know. You work in something with 200 micrometers as diameter, and then you start to play with you dry, not dry. I don't know. To be honest, I don't know. So what I know is that do not leave any sodium hypochlorite or EDTA inside the root canal thinking that, okay, it's enough. It need water, it need moisture to set up. Otherwise, do not try. I agree with the EDTA. Do not leave any EDTA inside the root canal.
Thank you very much to both of you for your great feedback and valuable opinion. So I think this will be it. This will be the end of our webinar. Thank you all for attending and for the great question you asked. Thank you very much to both of you, Dr. Kunyuth and Professor Simon, for your great presentation and for being here to answer everyone's questions.
Thank you.
Bye.
Thank
Bye.
you.